Well, good evening again, everyone. Welcome back to our Exam Pro webinar continuing series for the November and December oral board examinations. I'm your host for tonight, Rob Pegues. We will get right to our case list since we are doing today, as usual, on Sundays and Tuesdays. Case list defense. We would like to, in the coming hour, talk with as many of you as would like to spend a few minutes discussing a case. So please do just click the raise your hand button when we're ready. I think we have everyone's case list up and available here, and we should jump right in. So anybody would like to participate? Oh, Dr. Neely, thanks. Welcome back again. We talked just a few days ago. Go and see if we can get your case list more easily here. There you are. Thanks. Hang on. All right, Dr. Neely, there you go. Unmuted. Can you hear us okay?
Yes, sir.
Hi, welcome back again. Thanks. What should we chat about this evening?
Whichever one you want to go to is completely fine.
Okay. Well, you kind of get to choose. Yeah, you go ahead.
Let's do OB then.
OB. All right. Let's see if I get you up here for a moment. There we go. As I recall, your OB list does have a fair amount of stuff on it. Let's see. Yep, we're good. Let's cruise back in here for a moment. We'll find something maybe we haven't talked about recently. Let's see. We have, could we talk about your case 29? Because a BMI of 61 is kind of an outlier, but advanced obesities are kind of a thing in the exam for this year. So we maybe find something to talk about that for a few minutes?
Sure.
Good. So I think, first of all, they'll ask for a list. When you have a patient with a BMI over 50 or so, could you give us just whatever is your top maybe 5, 6, 7, or 8 things as far as risk to her pregnancy that do not really turn up with a person of normal BMI? We'll just pick one and go from there.
Sure. So she has a higher risk of gestational diabetes, interuterine fetal demise, has a higher risk of C-section, higher risk of wound complications after the C-section or wound breakdown.
Sure.
She has higher risk of growth abnormalities in the pregnancy, higher risk of hypertensive related disorders and preeclampsia.
Yep.
It's kind of the biggest things I can think off the top of my head very quickly.
Good thing to start. Why might she have a higher risk of fetal demise in the pregnancy? Are there some underlying reasons for that you're aware
of? That's a very good question. As it could be perfusion related or placental disorders could be related to those kind of things, I would think.
Okay. Could it be anything endogenously related to the fetus? Clearly, I think the things that turn up most in our minds are maternal disorders and placental dysfunction. Could there be anything intrinsic to the fetus that might be of higher risk in a patient of a high BMI that could lead to fetal loss at any time of the pregnancy?
In a patient like this, I guess endogenous or just through the pregnancy itself, that's not maternal related.
Sure, just maybe something more intrinsic to the fetus. Are there things intrinsic to the fetus itself that might contribute to this increased risk?
I mean, I guess growth restriction could certainly. I mean, in those cases, if the baby is growth restricted, is a separate kind of thing. Certainly, I guess I guess it's more related to hypertensive disorders, but I was going to say like placental abruption or placental issues. Nutritional status, I suppose, or abnormal glucose or anything like that.
With women of very high BMI such as us, is there an increased risk of fetal aneuploidies relative to the general population?
I'm not sure if there's a high risk of aneuploidies that I'm aware of. I mean, I guess there could be some increased risk of abnormalities such as neural tube defects.
Okay. Well, would fetuses of women with a high BMI have an increased risk of structural abnormalities relative to the general population?
Yes.
Yes, that's true. Increased risk of aneuploidies. You said not sure.
Yeah, I would say not sure.
Yep,
So I could.
apparently they do also. So the risk of fetal demise, I think, would be a concern. When in the pregnancy would you be concerned about this particular woman having a higher than average risk of loss of the pregnancy?
I think ACOG recommends for a patient that's has a starting BMI over, I think it's 40, you would start NSTs at least weekly at 34 weeks.
But when in the pregnancy, if you were talking with
Oh,
her about it, when in the pregnancy would you have concern that she is at increased risk of loss of the pregnancy or fetal demise?
I think that their rates of stillbirth are essentially equivocal at 30 in the 39th week, as a normal pregnancy is closer to like the 41st or 42nd week. So that's why, generally speaking, we try to deliver them kind of, at 39 weeks or so in the 39th week.
So you're saying up to the 39 week, the risk of fetal demise would be the same as the general population?
I'm sure it's higher than that. That's why they also recommend the NSTs a little bit sooner at the
Right.
34 week mark.
It
I don't know if there's an exact cutoff from that standpoint. I do know it's higher than baseline, which
is
I think
definitely
why they also obviously recommend at 34 weeks doing the weekly NSTs.
yes. Is she at increased risk of first trimester fetal loss with her
Yes.
BMI? Yes. Is she at increased risk of second trimester loss with her BMI?
Yes.
Yes, she is all through the pregnancy. So it sounds like you're going to do third trimester antenatal testing, but this risk exists throughout the pregnancy. Are there other things that you would be doing for as far as prenatal care, which might help to either to reduce the risk of fetal demise in this pregnancy, or to identify factors which might lead to it, so that we might reduce the risk that way of it happening?
Yeah. This patient I should have been started on. I mean, I assume that she was. It doesn't say obviously on my list, but she should have been started on aspirin at at 12 weeks to help reduce the risk of preeclampsia.
What
Hopefully, also she would have.
what dose of
Um,
aspirin would you use for a woman
uh,
with a BMI of 61?
we typically use 81 milligrams of aspirin. Some of the high risk specialists do recommend two, so 162 milligrams, but we typically use 81 as a general practice in our
I'd,
group.
I'd stick with that. We don't have any specific recommendation based on BMI, although one would think so. But you're right. No, 81. I'm sorry. Go ahead. I just wanted to be
Okay.
sure we talked about that.
So she'd have got early preeclampsia lab just for baseline, including 24-year protein and all those kind of things. Early glucose screening whenever she presented,
Very good.
given those things. Certainly, a morph scan, and then usually a growth scan at 28 and 32 weeks, as well, and then starting at least weekly NSTs at 34 weeks for this patient.
Okay. Is there anything else that might be a component of your prenatal care which might help to reduce the risk of loss just throughout the pregnancy?
Certainly, this patient should be counseled that she shouldn't gain. She would be in kind of the very low kind of weight class of any kind of weight gain or minimal weight gain throughout the pregnancy, as well.
Okay. Good. Now we talked about things intrinsic to the fetus. What would you offer this patient in the way of screening for aneuploidy?
I think that certainly just because of increased risk, you could offer her either cell-free DNA, or you could offer either an early kind of first trimester ultrasound with screening, and then also a quad screen, so kind of a sequential scan or sequential testing with those kind of low risk modalities, or an NIPT with cell-free DNA.
Ah, good. Okay. How would you counsel her about the sensitivity of NIPT or cell-free DNA for her?
Um, NIPT, I think, has a sensitivity in the upper 90s. I think 97%. So, in the case of a negative NIPT, you're pretty certain. I mean, although again, if morphology dictates otherwise, then you could offer some other form of testing. But if her NIPT is normal and then her morph is normal, that would be overall very reassuring that there's an overall very, very low likelihood that there is kind of a chromosome abnormality.
So you're quoting the standard sensitivities for NIPT there?
Yeah, I assume that it may be a little bit reduced for her, but I believe it's in
Yeah.
the upper 90s is the
Yeah.
baseline.
That's a question. Would you give her those numbers, or would you give her different numbers based on her BMI?
I would probably tell her there's a slight reduction, that I would have to look up the exact percentage of the
There,
sensitivity for her.
There is a reduction, and it's enough to be important, and it's important for us to counsel her about that. So one of her issues is she has an increased risk of aneuploidy, and we are going to be less likely to pick it up if it's there. That's a hard thing to get around. Structural anomalies. I'm assuming you're doing detailed anatomy ultrasound at 18 to 20 weeks or so. If her anatomy ultrasound is normal, how would you counsel her about the sensitivity and that the anatomy has been proven to be normal?
Certainly for her, it's going to be reduced just because of
Yep.
just difficulty in imaging and
Exactly. And no, absolutely right. Biophysical profiles, are they less sensitive in detecting sort of abnormalities or in scoring in a woman of very high BMI?
I would also say so because the difficulty of ultrasound, difficulty in capturing everything you need to capture in terms of even movements or breathing episodes as well. I would assume it is reduced as well.
True too. What I would say, I think, in the exam is that there may be some decreased in accuracy in identifying an abnormal biophysical profile. There also may be some issue in identifying a normal biophysical profile. We might be a little bit more likely to call an abnormal one based on not being able to see things like fetal breathing movements well, based on difficulties in assessing sort of fetal tone and the other components of the biophysical profile. So we might. It might be an artifactually low biophysical profile of this woman. There also might be an artifactually high one, and there are problems either way. Good, great. We just sort of took this case wherever it went. Jared, is there anything else you'd like to talk about that? I think we got some good information there, but that's the people of high BMI, I think, are more likely to turn up on structured cases in the oral exam also for these reasons.
No, that's perfect. Thank you very much.
Good, thank you. Thanks for doing that with us. Appreciate it. Let's move right along. I think Dr. Fitzsimmons might be next. Christine, I'm going to go get your case list while we are getting you up here for just a moment. Let's see.
Hi, how are you?
Hi, there. I just got your case list for a second. There we are. Got GYN and office practice here, ready to go. If you want to talk about something on OB, I don't have your case list here, but we can talk about anything. We don't necessarily have to see a case, but whatever you'd like to do.
Either one.
Okay, your choice. I'm good to go wherever you want.
We can do office, I guess.
Sure, that's fine. As you're studying, have you just in the past several days a week been looking at any topics on office that you would definitely like us to talk
about? No, not in particularly. I apologize if I sound crappy. I have a cold.
Oh, that is okay. There's a lot of that this time of year. No problem at all. I hope you're feeling better as the week goes on. Let's see. We have a bunch of stuff going on here. Let's see here. Just cruising through to see what we have here as far as screening. Good. The top. So your case list has a particular bent to it, which the examiners are going to notice right away. One of the things that everybody does need to get questioned and grilled about in the exam on GYN on office practice, and GYN is urogynecology, pelvic floor prolapse, stuff like that, and they will pull that up either in GYN or office, and you quite often talk about it twice. You don't have any cases on here, I think, that actually direct for that, so they're simply going to make one of those cases, something like it, and they'll pick a case at random. They might actually just pick a case number one and just take all the cancer stuff out of it, and just say, so if a 73-year-old comes in because she has recently noticed that she has a sensation of pelvic pressure and she wipes after going to the bathroom, she sees a bulge. And this is new for her. She's a new patient to your practice. How would you begin an office evaluation with that particular companion, a 73-year-old who we're going to say is otherwise healthy?
So I would initially start by doing a full history, asking her if there's anything in particular that makes the bulge worse, when she first noticed it, if she has any other associated symptoms such as pain, any changes to bladder or bowel habits. And then I would do a physical exam. I would start with a sterile speculum exam, take a look, see if I see anything bulging that would be suggestive of a prolapse, and then in the office that day, I would do the prolapse staging with the Baden-Walker system to determine the stage of prolapse.
And then on your exam, what particular structures are you looking at that might be involved in prolapse?
So it can be either anterior, it can be posterior, or it can be the vaginal vault or central apical prolapse. So when you're assessing the rate of prolapse, what you're looking at is with Valsalva, how far down the lowest presenting part goes. And you're looking at that with relation to the hymen. You're also looking at the perineal body and the total vaginal length, as well as the genital hiatus.
Good, great. So you mentioned, I think, 3 compartments of prolapse. You said anterior, which I'm assuming means cystocele. You said posterior, which I'm assuming means rectocele. And central, which is either uteroprolapse or uterovaginal, depending on whether they have a uterus or not. Are there any other compartments that we should be considering in evaluating pelvic organ prolapse?
You can also have an enterocele. So that's where you have bowel. Bowel.
Yes. And anything else aside from that? There should be one more compartment, which you just alluded to briefly when you were talking about how you grade.
Paravaginal, I guess.
Paravaginal actually isn't part of it, weirdly enough, because that's actually, yeah, funnily enough, that you make note of those things. But so far we got a cystocele, enterocele, uterine prolapse or vaginal prolapse, and enterocele. And the outlet support, or the perineal body, is actually important. And when we're considering surgical pairs, that's an important component of helping with that. So that's the 5th. Question we've talked about earlier in the season, which might I think commonly come up in the exam. Could you describe for us on an exam, how do you discriminate the difference between a rectocele and an enterocele?
I know for an enterocele, you're looking, that there's a between the anterior and posterior to see if there's any with Valsalva, any prolapsing of the vaginal tissue. With a rectocele, on rectal exam, you'll be able to feel, prolapsing into the vaginal wall and being able to come down. But beyond that, I can't.
So if there's a rectocele and the patient valsalvas, will the rectocele protrude into the vaginal vault?
It does. It does not. It does. Okay.
Yeah, if you have a chance on an elderly person, try it again. Yeah, they will definitely. Yeah, if they strain down, you're going to see some protrusion into the vaginal vault. You said if you have them strain, you'll see an enterocele also. But since they both do sort of protrude with straining, can you describe again the difference when you're doing an exam? Sort of anatomically, how do you, if you're looking for, how do you just figure out what's rectocele and what's an enterocele?
To be honest, I wouldn't know how to answer this question beyond intraoperatively.
Okay, well let's do intraoperatively. How would you discriminate it?
So I would look for any when you've removed either the uterus and you're looking at the top. You'd be looking for at the paravaginal tissue adjacent to where the cervix is, if there's any bulging of the anterior and posterior wall of anything that or weakening of tissue that could have a enterocele. So at that point, you would do a McCall coldoplasty.
Okay. So is an enterocele anterior or posterior?
Isn't it kind of paravaginal?
If you were looking, had a big speculum and looking up at the cervix, and you had the base of Valsalva, where relative to the cervix would you see the enterocele? Anterior, posteriorly, or laterally?
Laterally.
Should be directly posterior.
Directly posterior. Okay.
Yeah. Can you describe what structure is? You said you do a McCall's coldoplasty. What actually structure is involved in the enterocele? What does the enterocele consist of?
The McCall coldoplasty uses the peritoneum and the uterosacral ligament.
Yes, that's true. But we're trying to obliterate a structure. You're right. And what is that structure that we're trying to obliterate in there? It's posterior, because that's where the uterosacral ligaments come.
I mean, that'd be the posterior cul-de-sac.
It's the cul-de-sac, exactly. So if we're doing an abdominal hysterectomy and you were looking down behind the uterus and cervix, and you see the rectum coming up, and between the cervix and the rectum, that pocket in there is actually the cul-de-sac. And with an enterocele, that is what protrudes down below the cervix into the vaginal vault. So how is a rectocele different from that then?
So the rectocele would be, I guess it probably would start Hmm. Um, so a rectocele would be the posterior wall and
Very good.
um,
Right, posterior wall of what? You're exactly right.
I mean of the vagina.
Exactly, yes, exactly. And what's on the other side of the posterior wall of the vagina below it? What's the structure that causes the rectocele?
I mean the rectum.
The rectum, yes, exactly. So, so with an
You're making this
interstitial,
more complicated than it needs to be.
okay. We have to verbalize this exam, and this is one of those key things. So we're going to work out. You're great. So the cul-de-sac actually is a protrusion of the peritoneal cavity when you have an interstitial down below the cervix, right? You see that bulge at the top of the vagina, but it's always posterior, and it's actually just the lower peritoneal cavity, which does usually have bowel or mentum or something in it, right, protruding below the cervix. So that's actually an actual space. It's a peritoneal cavity protrusion behind the cervix. When we talk about a rectocele, is that actually a space that's protruding into the vagina? I mean, the rectum is there, but is it actually the rectum that's protruding into the vagina?
I think it's the pararectal space.
It's the wall, exactly. Pararectal, there you go. It's a pararectal space. It's a potential space. So you've got vaginal mucosa and submucosa and musculature there, and then you've got the fascia, right? And then you've got the the muscular wall of the rectum and the rectal mucosa and submucosa. So it's layers like that. And what's the defect or the weakness that causes a rectocele? Of those tissue planes that we just talked about, what's the one that weakens that causes the rectocele?
Um,
Is
I,
it the mucosa and submucosa, the musculature, or the fascia?
I believe it's the fascia.
Fascia, it's the fascia. Yeah, it's a weakness of the fascia, exactly. So when we do a rectocele repair, we dissect down to the fascia, we get that off, and then we placate the fascia, right? And that sort of thickens the muscular wall. With a interstitial, we don't have any of those tissues. It's just peritoneal membrane. So then a coloplasty is bringing the uterosacral ligaments together to obliterate that space where, between the cervix and the rectum, where that would be, and close that off so that there can't be a herniation or a protrusion. So when you're doing a rectal exam, how do you feel? Just real quickly, I'm gonna let you sit down. How do you feel? How do you identify a rectocele when you're doing a rectal exam with your finger?
So you can, if you're doing a rectal exam and they're in the, if they're asleep, you can feel the defect.
Yeah,
And you can,
yeah.
yeah,
It's a thin rectal wall, and if you push up on your finger, it sort of protrudes into the
you can
vaginal
see.
wall. How would you identify an interstitial by doing a rectal exam? Where would you go?
You'd have to go back behind the cervix and
Yes, exactly.
reduce um,
That
that
exactly into the cul-de-sac. Yes. So the key term I think you want to use is the rectovaginal septum. That's the tissue between the vaginal posterior vaginal wall and the anterior rectal wall. And the defect, that fascia, is the rectovaginal septum. If you take your finger up far enough, you come to the end of the rectovaginal septum. And above that, you are in the peritoneal cavity, right? So if you're
Mhm.
thinking about doing an abdominal hysterectomy and looking behind the uterus and the cervix in that space there, and you had a colleague do a rectal exam and come up like that, you'd see their finger kind of pop up and the rectum would be pushed up into the cul-de-sac because they're above that solid rectovaginal septum. You could see their fingertip because the rectum is in the peritoneal cavity. Does that make sense?
Mhm.
So the rectocele is rectovaginal septum on down. Interstitial is above the rectovaginal septum. And so if you do it next time you do a rectal exam, if you go far enough, you can feel that V where the rectovaginal septum divides, and that in that V there is actually where you're popping up into the peritoneal cavity through the rectal wall. So if you can this is really important for exam for all of our candidates, just grab an atlas and look at that and just sort of be sure that you can describe that relationship, because that's an important question in the exam. And if I were standing behind you, because watching you sort of work the stuff on the OR, I would see you doing everything that we talked about, because we understand it, but being able to verbalize it is difficult, which is why I wanted to be sure we walk through that. Good.
Thank you. I
Thank you
appreciate
for
that.
doing that. That was actually, once again, a really good discussion. Thank you for letting us do that. Let's go. I think we're going down to Dr. Wong, Dr. White. Let's do Dr. Wong for just a moment. Let's coming to you in just a second. We'll get your case list for a minute. Just a moment here.
Hi,
Hi, how are you? Oh, there
doing
you're
well. How are you?
up here. All righty, ready to go. What would you like to talk about this evening? Got your entire case list right here.
I would like to talk about office, please. I don't particularly have a specific case.
That's okay. That is all right. Let's see. Is there a topic that you're particularly interested in, or I can pick anything that you like. We'll just sort of go down here, maybe pick something relatively random we haven't talked about.
You can pick.
Let's see. Let's see. That's good. Could we do case number 29? Just because it's so simple. It just says right ovarian cyst. I don't know anything else about it. Now it's on the right side. Got a pelvic ultrasound. It says resolution of cyst. So this is a young 20-year-old woman. Was this something that you identified on an exam, or did her pediatrician or primary doctor send her in to you?
I had identified it as she, in her earlier visits, she had actually had a positive pregnancy test, and so we were doing
Oh, I see.
a bedside ultrasound at her initial visit to evaluate, the potential for an early pregnancy, and we found this cyst incidentally.
Got it. So in general, if a 20-year-old comes in and on a pelvic exam, you feel a right ovarian cyst, in a 20-year-old, what would be a basic differential diagnosis that would start to form in your mind as far as what could cause a adnexal cystic mass in a 20-year-old patient? We're going to say that she's a gravida 0 paracero. She is not pregnant.
Okay. First thing I would think of would be a physiologic follicular cyst. She could also have a hemorrhagic cyst, perhaps a teratoma. She could have an ectopic pregnancy. She might have. Oh, do you want me to keep going?
Yeah, keep going. Yeah, you're doing great. Yeah.
She, perhaps could have a fibroid that could be maybe pedunculated, a serosal pedunculated fibroid. I would, have a lower suspicion for something like a hydrosalpinx type of process given her age.
Sure.
And then in terms of, I guess, GI pathology, she could even have something like, perhaps like I'm hesitating to say this because I don't want to bring it up, but like a Meckel's diverticulum.
Now, I'm honest. Now, there are things in the exam we want to be careful about saying, like we don't want to jump into cancer right away because then they'll make us talk about weird tumors. You can throw out a Meckel's diverticulum because seriously, no gynecologic examiner wants to spend any time talking about that. So they're just going to steer you back. So you can get away with that. If you said it could be if you could be an estrogen secreting ovarian tumor, then they're going to make you talk about granulosa tumors. So we don't. So good. So based on that, what would on that differential diagnosis, how would you evaluate this at a first office visit? What on your examination, first thing you talk about in the exam, how will you object? So what information do you want to get from a pelvic exam regarding this cyst? Sort of walk through what particular findings do you want to identify as far as figuring out what this is based on physical exam alone?
So I would want to perform a bimanual exam specifically to be able to, possibly palpate the mass or, suspected cyst, and identify if the patient has any tenderness associated with palpation.
Good, tenderness. That's great. What else would you want to learn about it by doing a bimanual exam?
I would want to assess the size, potentially the, I guess, mobility, but I think that has a lower sort of sensitivity.
No, I think that's important. I would mention that. So we got what side it's on. We do want to know is it symptomatic or tender at all? Size, mobility. I think that's important. What else can you learn from just sort of a sensitive bimanual exam?
I mean, in an outpatient setting, particularly, that would help me stratify the risk of this, complaint. Meaning, do I have a concern for a potential acute abdomen process versus something more benign?
Good. Yes. Just by feeling this, is there anything else, any other information you can get from it, or anything that you might identify that would help in figuring out what this is, aside from you said tenderness, size, and mobility?
I mean, I think if the cyst were big enough, you could potentially assess. Actually, no, I'm sorry. I take it back. I was going to say maybe like if there was like fluctuance to it versus more of like
Yes.
a
Very
solid.
good. No, that's important. I think examiners want to hear that. You can actually tell the consistency of that. Is that a good word for it? Does it feel hard or solid or rocky, or are we dealing with something cystic? And is it cystic? Is it a tense, firm cyst or a fluctuant cyst? So that
Mhm.
is important information in figuring out what this is, because if there's an endometrioma, it's going to be more tense and firm, and if it's a hemorrhagic cyst, it's going to feel more fluctuant, right? And if it's a mucinous cyst adenoma, it'll probably be sort of in between. Does that make sense?
Yes.
I think that's I would absolutely mention that in there. Good. And Morano, aside from that, sort of feeling the fluctuance or that character of it, is there anything else on feeling this thing that would be important to identify?
I'm not sure.
You're going to sort of feel the contour of this. On your examination, will you be able to tell if it feels smooth or whether it feels irregular or nodular? Uh, can you tell things like that on your bimanual exam?
Possibly.
Yeah. Oh, yeah. I know. I'm sure that you could. If it's of any significant size, you could. And that's
Mhm.
important as well, as far as sort of figuring out what this is. Good. So I think that's a good list, but I would really want to is symptomatic in any way, tenderness or pressure, size, mobility, the consistency. Is it hard, soft, firm, fluctuant? And then the sort of the surface of it. Does it feel smooth capsule? Is it irregular capsule? Does it feel nodular? Is there excrescences? Does it feel sort of rocky, like it could actually be a solid mass like a fibroma or something like that? Lots of good information to get from that. So having done your exam, then we should talk about office evaluation, laboratory testing, and imaging. What would you want to do?
Mhm. Um, so if I did a physical exam where I was not suspecting a size greater than 10 centimeters, limited tenderness, no sort of abnormal nodularity. And if I'm sorry, did I get an ultrasound already?
No, I'm just asking. You've done a physical exam. Now, what testing are you going to get? Could you talk about laboratory testing and imaging? What would you be ordering here?
Oh, I see. Well, given the age of the patient, and I would probably start with an ultrasound and defer other lab testing until the findings of the ultrasound.
Okay, so really, is there any laboratory testing that you really want to get on this visit in a 20-year-old who hasn't had an exo mass?
I'm sorry, I would order a urine pregnancy test.
Of course you would. Yes, you definitely get some sort of pregnancy test first. Everything else I think is fine, but she's got to have a pregnancy test. Good. So we'll get a pelvic ultrasound. And what can we learn from the ultrasound in addition to our exam? When you're reading the ultrasound report, what words or findings do you want to pull off there that are going to help you figure out what this is?
So I would be looking for the size of the
Yes.
mass,
Good.
and I would be looking for any characteristics that might suggest potential malignancies, such as increased vascularity, complexity of the mass, septic septations, excrescences, papillations. Um,
Good.
what else? Mhm.
No, I think you've got a good list there. Exactly. You want to know sort of the internal structure: simple, complex, septate, partially solid, right? Heterogeneous. Any signs suspicious for malignancy, excrescence, and papillations. The size of it, obviously, and it's unilateral, not bilateral. It doesn't seem to be separate from the uterus. You mentioned maybe a pedunculated myoma. Are we uncertain whether this is uterine or adnexal? Those are all good things we can learn from the ultrasound. Good. So if this turns out on your exam and ultrasound with a negative pregnancy test to be a 7 centimeter complex right ovarian cyst without any other particular findings, nothing internal or external. Now, what's your differential diagnosis?
Mhm. Now I might be, more concerned for teratoma, a hemorrhagic cyst.
Good.
It sounds like the characteristics of the cyst, didn't have other, signals of potential malignancy. So I would have a low. I'm sorry. I would probably defer, other serum testing at this point, given her age
Good.
and the size of it.
Good. If you said so, is teratoma or hemorrhagic cyst sound like they're on the top of your list? Based on your exam and the ultrasound, what could help you determine whether it was a teratoma or versus a hemorrhagic cyst? Would the ultrasound have any particular findings there that might help you?
Yes, with a teratoma, you could see some more sort of heterogeneous contents, including solid components. And with the hemorrhagic cyst, you might see that I'm forgetting the term now, but sort of the homogeneous but intermediate echogenicity of like blood, essentially, in the.
That's great. Good. So if there's no signs to suggest a teratoma, it is just sort of the ultrasound says highly suggestive of hemorrhagic cyst. Let's make that easy. And it's 7 centimeters, and it's a little uncomfortable when you examine the patient, but not much. What would be your recommendations as how to manage that?
Mm-hmm. Excuse me, I would counsel the patient that she has options depending on what works best for her and what her preferences are. And that could include expectant management, given that it's less than 10 centimeters. I think that if patients are in extraordinary discomfort, then even though it's less than 10 centimeters, it's reasonable to move towards operative management.
Agreed. But you'd be comfortable if she wanted to observe it, observing it?
Yes.
Sounds good. If you're going to observe it, then what would your follow-up consist of?
I would probably have her come back in, perhaps 2 to 3 months for a repeat ultrasound and repeat pelvic exam, so we could further assess if there are worsening of her symptoms or growth of the cyst. And I would tell her that at any point in this time of expectant management, if she were to have worsening pain, that I would recommend immediate evaluation.
Good. And final question. This is the one the examiners always want to get to. So on this 3-month follow-up ultrasound, what findings on this ultrasound would make you decide to recommend to the patient that she really should have surgery rather than continuing to observe this thing?
Mm-hmm.
Based on your initial ultrasound, what on the follow-up ultrasound would make you change your mind?
If there was growth of the cyst, particularly if it was greater than 10 centimeters, or if I were concerned of a potential torsion.
Okay, sure. Anything else? So increase in size. I'm assuming you're talking about acute findings relative to it, like acute symptoms or loss of blood flow or something like that. What else might you see on this follow-up ultrasound that would maybe different in a way that would change your plan for it?
I suppose if there were more findings that were suggestive of malignancy, then I might also recommend surgical management.
Good. Sure. Anything else? That all sounds good.
I'm not sure.
Now, you talked about sort of findings of acute findings. If everything were the same, but the patient were now symptomatic, how would you consider that?
I think if the patient, was more uncomfortable, I think it would be reasonable to intervene surgically.
Good. Okay. If it were complex before, if it said increased complexity in comparison with the previous study, would that in any way influence your thoughts about how to manage this?
I guess that would depend on my initial working diagnosis. For example, if I had a high suspicion for a teratoma and there were more complex features of the cyst, I might be less concerned, given that that is something I might expect. But
that's a reasonable answer, and the examiners would throw out something like that. It was really kind of non-specific, and then when you said that, they said, well, suppose, and then it would give you something that's a little bit more specific than complex, or they say, suppose it was minimally complex before, and it's now called highly complex in 3 months. How do you feel about that?
Yeah, that I would find concerning.
Good, exactly. They're just going to ratchet it up until then. They want to find the point at which you would operate on it. And I think any clear change over a period of 3 months in complexity or internal architecture may really mean that we might, even a 20-year-old, we might want to talk about at least doing a cystectomy here. I think that would be fine. But I think you were right down the line on all the things you would consider as far as an initial evaluation of this. And really, the important thing in the exam is we do want to practice to ourselves just sort of on a physical exam. What can we learn from a physical exam and discuss anatomically sort of there and things like, not just this, whether it's tender or not, or the size of it, but how does it feel? Can we tell the internal architecture from pressing on it? Can we tell the external surface from pressing on it? Its mobility, is it regular or lobulated or irregular? Does it feel solid? There's lots of words we can use to describe that. And it's important for the examiners to be able to hear us doing that. If I were to stand behind you in the office and watch you do this, I would be able to tell that you were sort of assessing all that stuff. We just have to, again, learn how to speak about it. That's all.
Mm-hmm.
Good. Melissa, thank you very much. Would you like to ask any other question about this case before we move on?
Yes. What's the term for, like, the radiologic term for like a hemorrhagic cyst? Is it ground glass?
Ground glass sounds a little bit more to me like like an endometrioma, but it's really blood. Ground glass is blood in there, so I think hemorrhagic cyst, possibly some people might use it with an endometrioma. I think it could be either one.
I see. Okay,
yeah.
Thank you very much.
But they'll be described as complex, and I think a standard hemorrhagic cyst would be minimally complex, probably. That might be what they said.
Got it. Okay, thanks
Good.
very much.
Thank you. That was actually great also. Let's go back here for a moment. Let's go to, let's see. We had Dr. Diaz just left us, so I'm going to go to Dr. Wagner for a minute, and then maybe Dr. Zafra. Dr. Wagner, I'm going to go get your case list while we're waiting here for just a moment. We're right down here. I thought you were. Let's see, Ruth, if you can unmute yourself. I'm looking for your case list, but for some reason I'm not finding it. There we go. Ruth, can you hear us okay?
Yes, I can hear you. I think I'm in the October.
Oh, okay. I'm sorry. Well, let me just.
And sorry, and I'm under Claros as well.
Oh, I said you're under what's the name?
Claros, CLAROS.
Okay, good. Let me go back. Let's see if by chance you're here, and if not, I'll just move to October. Give us just a moment here. Let's see. Claros. Oh, you're here. I think that's you. Let's see if that's you. Looking good. I think we might be good. Okay. I think we have you here. So where would you like to go? We'll spend maybe about 10 minutes talking about something.
Well, since we just did office and OB, we can do GYN.
That's fine, sure. Any topic or case that you've been looking at recently that's been of interest to you? Or I can just pick something.
You can just pick something.
Great. Okay. Let's see. Can we pick case number 4 right at the bottom of page 1? This page 1 seems to be popular with examiners. So we got a 26-year-old null-gravid patient. We've got AUB, not otherwise specified. We have PCOS, have a suspected endometrial polyp. In a patient with PCOS, if you see a structural lesion or suspicion of an endometrial polyp, does that raise any particular concerns or differential diagnosis that you would not have so much in a patient who did not have PCOS? In other words, I think what I'm asking is would a structural lesion like an endometrial polyp possibly mean something different in a PCOS patient than in a patient who did not have PCOS, but who had AUB?
I mean, I guess the only thing that I would think about is because they have PCOS, they are exposed, or they're unopposed estrogen exposure. And so then I would just think about the risk of polyps or hyperplasia.
Good that you went right to it, and that's what the examiners would be waiting for, is just so we recognize that. And once you've said that, I think you probably have passed for this case, and the rest of it is they're just going to have a nice conversation with you. But let's carry it on a little bit further. That was a pass-fail point right there. Good. So so in this patient, then, how do you value? You have an ultrasound that suggests a polyp. You have a little increased concern for premalignant or malignant conditions, it sounds like. How would you counsel the patient about this? First of all, how would you talk to them about what it might be and what your concerns would be, and can you give them any percentages?
So I would say, with her being 26 years old, I would say that my concern is a little bit less as compared to someone if she was like in her 40s. I would also look at her, BMI, or look at other risk factors that she could have for, again, more estrogen exposure. Um,
But
yeah.
as far as describing it, sort of, you have a polyp in there. You said you're a little bit more concerned it could be more than a polyp. What particularly would you discuss with her? What things would you bring up that you'd want her to know about what you're thinking this might represent? What specific
Um,
diagnoses would you talk about with her?
I guess I would talk about just it being a benign polyp, or I guess like I mentioned before, I would also counsel her on this could be just I guess simple benign hyperplasia, or then EIN,
Good.
and then I don't think I would mention an endometrial cancer in a 26-year-old,
Hmm.
but maybe I should.
Is there any possibility that this could represent an early endometrial cancer in a 26-year-old with PCOS?
I haven't seen it in a 26-year-old, but I mean, I guess it could.
It could. Yes, the answer is yes, possibly. If she has a BMI of 40 at the age of 26 and she menstruates once or twice a year, then she has prolonged periods of unopposed estrogen, and it is possible. Yeah. Not
Mhm.
likely, but possible. Yes. So how would you continue your evaluation of this endometrial polyp finding on ultrasound in this patient?
Mhm. Yeah. So, in my practice, we don't have the ability to perform a saline infused sonohysterogram, and so then I would counsel the patient on a hysteroscopy DNC, and then with a polypectomy
Good.
using the MyoSure device.
Good. Great. Um, Now, important question here. When you're using your MyoSure, you're doing a polypectomy. You said DNC, so you're also sampling the endometrium.
Yeah.
Do you send all the specimens together, or do you send the polyps separately from the endometrial sampling?
I send it separately.
Good. Okay, good. If then your pathologist returns a histologic diagnosis for the polyp of EIN and of the general endometrial sampling of, let's see, you says benign endometrium, how would you counsel the patient about that and what that means for her?
Mhm. So I would tell her that when there's a diagnosis of EIN, there can be up to a 30% chance that there could be an occult endometrial cancer. Um, I would say that, it could have been possible that either it's just focal, so it's just in a polyp, or we just missed, the more of the cancer when we were doing the DNC. And I think I would still quote the 30%.
Okay, it's fine. So to be sure that you sent the polyp separately, the EIN was in the polyp. Your endometrial sampling was normal, and you did a DNC. Despite you doing good sampling, are you saying that it is still possible that she might actually have an endometrial carcinoma, even though you've completely removed the polyp?
Well, that would be more of a case, I guess, if I was doing the endometrial biopsy. Um, hmm.
Now,
Yeah.
now, I'm the examiner, and as the examiner, my job is to sort of push to see whether you'll
Yeah.
or whether you'll give way, because you just told me that there would be a 30% chance of her having a yet undiagnosed endometrial cancer because she's got EIN. The EIN was in the polyp, and you sent the polyp separately, and you sampled the endometrium, and your endometrial sampling was benign. The question is, given those findings, are you still telling her that there is up to 30% chance that she might have it as yet undiagnosed endometrial cancer?
Um, Gosh, I'm stuck.
I would like you to say yes, because the correct answer is yes.
Okay.
Because is our even with the DNC, is our endometrial sampling 100%?
Well, I would say no. It's better than an endometrial biopsy, but
It's
no.
60, people like to say it's 80 to 90%. It's 60% at best. But the point is, this is a woman who was able to develop EIN, right? It wasn't a polyp, but she developed EIN. Therefore, she has automatically, you have to assume she has that up to 30 or 40% chance of a coexisting endometrial cancer. Good. So she's 20, well, she's 26-year-old. She's nulliparous. She has EIN, and therefore she actually may have an endometrial carcinoma. How will you now manage her given this information and this risk?
Yeah,
And she is nulliparous, and she strongly desires future childbearing.
okay, well, that's gonna be my first question is if she desires childbearing. If she does,
Yes.
yeah, the recommendation is to try a progesterone IUD. Well, actually, I would refer her to GYN oncology.
There you go. That was
Yeah,
exactly the right thing to say. That's what the examiner was
for
looking for.
oncology.
So,
But I
but then
believe
what would the GYN oncologist likely recommend to her then?
I believe that they would recommend a progesterone IUD. And then from what I can recall or I'm aware of, usually it's about for a year and they do EMBs, I want to say like every 6 months or so, just to make sure it's not progressing.
True. Yeah. So first of all, we don't know that it's there, but they would sample to be sure that they were not picking up evidence of EIN or carcinoma. You're absolutely right. Now, what you did actually was, this is really important, Ruth, is you backtracked and you said you would send her to GYN oncology. We were on Sunday evening. We had about 3 hours of mock orals with our candidates, and we actually did have to talk about this once or twice. They will lead you into that. When they give you that scenario, they will say, what will your management be? And when we get into any issue where we're sort of talking about stuff, that says maybe more than 4 or 5 questions in, it's important to think to ourselves, am I still talking about things that is within my purview to do by myself, or do I need to refer to somebody else? And they will leave that question open to see whether you say, well, I would place an IUD, and then they'll ask you what type of IUD would you place, and then they'll ask how often will you sample her, and they're going to lead you into a situation where she develops cancer and we missed it or something like that. So in order to avoid that, you were exactly right. You're going to send her to GYN oncology, because the rule is if she has EIN, she has to go to GYN oncology as long as we have resources available. If we live in an area where GYN oncology is 4 hours away, we may have to do it by consultation by phone, but still, when possible, you gave her exactly the right answer. And you described exactly what the GYN oncologist would do. They would use progesterone treatments. IUD would be great. They do have to have serial sampling. It could be every 3, 6, 12 months, depending on sort of what the situation is. You're right, but they absolutely do. Yes. So you're right on top of every aspect of that case. I think that was nicely done.
Okay.
Any questions you'd like to ask about that before we move ahead?
No, and I think that's it. Yeah, I just need to not backtrack on my answer.
No, but you're okay. Yeah, I didn't say a word. You sort of decided that you want to turn around and go the other way, and then we just need to learn how to do that in the exam. I'm confident that in the exam you'll be able to do that if you need to.
Okay. All right.
Good. Thank you. See if we could get one more case in. Here we do. We may run over a couple minutes, but I'd like to see. Let's see. We could get. See, Dr. Diaz is back with us. I think she had clicked her hand up earlier. So Maria, I'm going to get you real quick and grab your case list while we're. Hey, Maria. Okay.
Hi there.
Hi, we're good. All right, got your case list right up here. We will go. We'll go a few minutes over. That's fine. So where would you like to talk about any particular part of your case list today?
Yeah, can we do some more office?
Sure, of course. Yep.
So
office.
So I have a lot of kind of sexual dysfunction, and I had postcoidal bleeding 3 times.
You do. You got case 4 at least.
Case 4, and then I think and then a few towards the back.
Yeah. So let's pick one. Is there a particular one of those that you'd like to pick? We'll do that. Go do case 4.
Case 4 is great. Case 4 is great because I think that's so. Basically, one of them is an ectropion, the other one is vaginitis, and then one is a cervical polyp. So maybe case 4 is the weirdest one.
Good. So let's see. Particularly, we'll keep this focal then. So this is a 40-year-old gravid para 2. Let's take the dyspareunia off. Let's see. She presents with new onset of postcoidal bleeding. Can you tell me what basic history information do you want to get from her?
Right. So when did it? So onset of symptoms. What? I guess what maneuvers or sexual positions or anything that she's doing, if it is associated obviously with penetration or toy use, if it is associated with any pain, abnormal discharge, and maybe a significant amount of bleeding versus just spotting, and if it is recurrent, like it happens every time, or maybe cyclical.
Perfect. You actually hit everything though. That the last part I think was really important. I was waiting to see whether we had come up with it. Is it consistent all the time or is it intermittent? And I really like that you added it is cyclical, because we're wondering, yes, she is 40 years old. I'm assuming she's still ovulatory and menstruating.
Mm-hmm.
Is there a menstrual cycle sort of month pattern here, which might clue us into that? So
Mm-hmm.
what would be your basic differential diagnosis with that? Let's say it is fairly consistent and we don't necessarily identify a pattern, but maybe so. What would be a basic differential diagnosis that you would start to work with in this 40-year-old?
Right. So I usually think of maybe anatomical issues versus infectious issues, or maybe like, I don't know, functional, like trauma type issues. So infectious, and I think of anything that would cause vaginitis or cervicitis, like STIs, trichomoniasis, GC chlamydia, even BV. And anatomical
Okay,
being.
wait, so let's move down for a minute. So you said trichomonas, you said chlamydia, gonorrhea, you said vaginal bacteriosis also. Okay, I mean I can go with that. Of
Yeah.
those, of those four that you which one or two would most likely be involved in postcoital bleeding if they were present? What would be your top two?
Sure. I think it would be trichomonas and oh gosh, maybe chlamydia.
I agree completely. Yes, I think trichomonas. I think of much more than bacterial vaginosis. Trichomonas definitely.
Right.
One of the hallmarks of chlamydia, which is otherwise asymptomatic, is painless postcoital bleeding.
Mm-hmm.
So in this case, she's got to have a chlamydia test. Good. I like that very much. So in those it's infections. Then you said anatomic issues. What were you thinking of there?
So it can be like a vaginal septum or something. She's 40, but someone young, or
Well, this is recent onset. So are there
sure. Okay. Right.
are
Right.
there
So
anatomic think of here?
like a cervical, like an ectropion, a cervical polyp.
Yep.
And then, or maybe like just like trauma if the intercourse is.
Okay.
You know.
Anything else anatomic that might be a 40-year-old that might actually be someone who has a recent onset of postcoital?
Sure. Yeah, of course. So you can't forget things like malignancy.
Yeah, rare. Anything that would be a lot more common than malignancy, although that's important to mention. In a 40-year-old who is a gravida 8 para 2. Yeah.
Oh gosh.
So she's had 2 vaginal deliveries, each one of maybe 4,000-gram infant.
So maybe she's had a history of like a laceration or cervical laceration, or.
Well, that would be a long time.
No, yeah, I know. I don't know if I'm sorry. I can't hone in on it here.
No, in sort of in midlife for women, or this is for with dyspareunia, also deep penetration dyspareunia, pelvic organ prolapse or displacement. If the cervix is way down, there's going to be more contact and sort of trauma with the cervix. So just pelvic organ displacement, things like cystoceles and things like that, they can cause postcoital bleeding also. So
Okay.
I put that in the list. So you said anatomic, infections, and trauma. I think we covered trauma. Anything else on the differential you'd like to drop in, or shall we go ahead and talk about working it up a little bit?
Yeah, let's talk about working it up.
Okay. So what will your office evaluation consist of given that differential diagnosis? Where will you go with sort of physical exam? Testing?
Sure. Physical exam, full, speculum exam, serospeculum exam, and bimanual. I would also make sure it's not like that from the bladder. So I would do a UA, pregnancy exam. I would also do infectious swabs like of vaginitis, chlamydia, gonorrhea, wet prep. And if that is negative, then I would also do a pelvic ultrasound to see if there's anything maybe above that can be possibly causing it.
What would you be looking for on the ultrasound?
Maybe any kind of, you said it's all of the time. So things that I think of that can cause postcoital bleeding. If she was cyclical, it would be like endometriosis or, some abnormal like intracavity thing. But
how would endometriosis cause postcoital bleeding? Because isn't endometriosis an intraperitoneal process, and we're talking about something that's down in the lower genital tract?
Sure. I know it's rare, but she can have possible like implants in the cervix or maybe in the vagina as well.
Oh, we'll give you that. That's good. Okay.
Okay. Kind of around.
Okay. So okay, but on ultrasound, is there anything else? Why are we looking at the ultrasound? What else do we want to know from the ultrasound?
Gosh, yeah. I mean, I really did an ultrasound for her for dyspareunia, so I'm not really.
Yeah. Okay, but for postcoital bleeding, it
For
also
postcoital bleeding.
yeah. So some things we haven't mentioned on our differential diagnosis that in a 40-year-old, if they were present, could cause postcoital bleeding.
Aside from like malignancy or maybe kind of a zebra like a leiomyoma or something that's prolapsing that can cause that, but I'm not really sure.
Right. No, right. And a submucous or intercapillary fibroid, could that be an
Okay.
issue?
Okay.
Because remember, because uterine contractions are a normal part of female sexual response. So if we've got a intercavitary lesion of some sort, a big polyp or something like that, postcoital bleeding definitely could be a thing. Intercavitary fibroid, I think clearly one. I mean, obviously a myoma that's in the cervix and not yet prolapsing, absolutely yes.
Okay. Okay. All right. Very good.
Yeah. So I think on ultrasound we get that. So to cut to the chase, and then we'll finish here in a minute. So if all of your STD testing, all your vaginitis testing completely negative, ultrasound normal as can be, the only thing on the exam is that she has a fairly large ectropion, but there is no infectious cause of it. Her pH balance, her saline, KOH, everything perfectly normal. How would you counsel her about it? And is there any possible remedy that we could think of that might be able to help her here?
Yeah. So I can tell her that it's kind of it's a variant of normal, and if it's causing her a lot of copious discharge or significant amount of bleeding or distress, then to my understanding, there's kind of some things like acidifying, vaginal acidifying tablets like boric acid that can possibly help to reacidify that cervical mucosa that's into the, like looking into the vagina. That's one thing that I did come across, as well as if it's something significant and very recurrent, then ablation, some type of like electrosurgery would be kind of.
Oh, well, tell me, what do you think about there? What's that?
So like cryo, or using the ball tip of like a bovie when you're after you do a leap.
Oh, I see. I understand. Got it. So you're
Yeah, cauterizing. Yeah.
Got it. Would a leap procedure be an option in a patient with this problem?
Yeah. So if a simple cautery doesn't alleviate that, then that would be like an excision. Then an excision procedure might be the next step.
So the examiner's next question is going to be: so is leap procedure a recognized management of a cervical ectropion?
No, it's not. I don't think so.
It's not. It's not. It's not.
No, it's not. No, that's kind of big.
I think we might have gone a bit too far there. I do know people
Okay.
who have leaps for things like this. The issue is you've probably done some leaps on people. When they heal, don't they have a little bit of an ectropion from healing from the leap?
Yeah,
Leap
they do.
doesn't get rid of the ectropion. It can just grow right back. Now the
Yeah.
freezing, the cryo, or the cautery, I think might actually be at least temporarily useful, because the ectropion is going to be probably a temporary thing. If this is a recent onset, she's probably not going to have this for the rest of her life. This may be due to maybe she's on some oral contraceptive or something else going on. So I think a topical ablative therapy is good. Again, the examiners will try to lead you to see if you'll take the bait. If
I
they
totally did. Yeah.
conization, and I would not. I'd say no. I don't. I don't think that's recognized. That's a little over aggressive, but I might do something superficial on the surface if the patient was really, really bothered by it. That would be fine.
Okay. All right. Fantastic. Thank
Good.
you.
You did a nice job of that. That was a good differential diagnosis. We got through some really good stuff about management. And these
I
things are
appreciate it.
sometimes troubling. The examiners will ask about it because these things are sort of troubling. They're often nothing more than an ectropion, and they really distress people, but there's hard to do very much about them. So I think the answers that you gave us to what to do are about the only things we could think of, and that is fine.
I
Good,
appreciate
Maria,
it. Thank you.
that was excellent. Thank you. We do have to stop for the evening. Thank you to all of our candidates who have stepped up here. And again, we will tomorrow, Wednesday, be doing, of course, structured cases, and Sunday we'll be right back to case list review. We'll get to the remainder of our candidates. Do remember, all of these sessions are again archived. You can go back and listen to them on podcast at any time since you are subscribers right up to the examination. Thanks for joining us. Have a great rest of the evening, and we will sign off for now.